Hoarseness is a common presentation in primary care practices. Combined with other voice-related changes, it falls under the umbrella diagnosis of dysphonia. Hoarseness has a number of causes, ranging from simple inflammatory processes to less common psychiatric disorders to more serious systemic neurologic or cancerous conditions. Medication-induced hoarseness is common and should be considered. The initial evaluation begins with a targeted history and physical examination, while also looking for signs of potential systemic etiologies. Treatment should begin with voice rest, especially avoidance of whispering, and conservative management directed toward a presumptive cause. For example, proton pump inhibitors are appropriate for hoarseness due to reflux, and proper vocal hygiene is recommended for vocal abuse-related indications. In the absence of a clear indication, antibiotics, oral corticosteroids, and proton pump inhibitors should not be used for the empiric treatment of hoarseness. Direct visualization of the larynx and vocal folds, commonly mislabeled as vocal cords, should be performed within 3 months if an etiology has not been determined or if conservative management has been ineffective. Patients who experience symptoms lasting longer than 2 weeks and who have risk factors for dysplasia, for example tobacco use, heavy alcohol use, hemoptysis, may require earlier laryngoscopic evaluation. Voice therapy is effective for improving voice quality in patients with dysphonia if conservative measures are unsuccessful, and it can also be helpful for prophylaxis in high-risk individuals, for example vocalists, public speakers. Surgical management is indicated for laryngeal or vocal fold dysplasia or malignancy, airway obstruction, or benign pathology resistant to conservative treatment. The most common cause of hoarseness in adults is laryngitis, which is classified as acute or chronic. Acute laryngitis is a common self-limited condition lasting less than 3 to 4 weeks. Common causes include acute vocal strain or upper respiratory infection. Short-term vocal abuse, for example singing, screaming, or protracted coughing, can cause microtrauma and focal vocal fold edema. Hoarseness is often part of a constellation of upper respiratory symptoms caused by viruses and less commonly by bacterial or fungal sources. Allergic rhinitis is another common cause of acute laryngitis. Chronic laryngitis is diagnosed when symptoms persist for more than 3 to 4 weeks. Long-term inhalation of irritants, usually through smoking, reflux, chronic vocal strain, and postnasal drip are common causes. Irritation of vocal fold mucosa by reflux can be caused by laryngopharyngeal reflux, LPR, or gastroesophageal reflux disease, GERD. Voice rest, especially the avoidance of whispering, is essential for the treatment of hoarseness. Neither antibiotics nor corticosteroids should be routinely prescribed empirically. A 3 to 4 month regimen of high-dose proton pump inhibitors should be prescribed only if the history indicates GERD or LPR, or if signs of chronic laryngitis are visualized. Inhaled corticosteroids, notably fluticasone, Flovent, budesonide, Rhinocort, and beclomethasone, can cause dysphonia in up to 58% of persons, more so in women, 3:2 ratio, and individuals older than 65 years. Gargling, rinsing the mouth, or drinking water, as well as using a spacer, may be tried if dysphonia develops, and the corticosteroids can be discontinued or given at a reduced dosage if the hoarseness fails to resolve.